as far as getting a letter of recommendation, typically it will be from shadowing. You will want to build that relationship with the PA to be able to ask them for a letter of recommendation down the line. Hi guys, welcome to e-shadowing. It's the last shadowing session of 2021. It's canceled next week as I'll be traveling, so no shadowing session for the 27th. So it's our last session. Hi guys, I'm Rodalyn, as you all may know. Welcome, and happy Christmas, Merry Christmas, Happy New Year, Happy Holidays, whatever you celebrate. I hope you guys are having a great holiday season and have a wonderful holiday this Saturday, and then next week Saturday again is New Year's. So yes, I hope you guys take the time to reflect, have some great New Year's resolutions, and yeah, and let me know how e-shadowing went for you guys. There's actually quite a few people that tell me they got accepted and are still watching e-shadowing or still tuning in, so I appreciate that. Thank you guys. I'm glad that you guys enjoyed that much to still watch it, even though you necessarily don't need to anymore since you got into PA school, which is amazing. Congrats. I'm glad that, it's enjoyable and entertaining. So I'm the host and the presenter for e-shadowing tonight. We're going to jump right in. This is going to be more of more like a Q&A as always, and reflecting, talking about how your year went. I always kind of like to have, chill moments, but I'm always, of course, going to still teach you guys tonight. I have a case study, and yeah, so we're going to do a few, half the time to answer questions, and the other half to do the case study and give you guys a chance to still learn if you have any questions. You always get every e-shadowing counts. If you're new to e-shadowing, all your answers, everything relating to e-shadowing is on e-shadowing.com. Whether I host and be a presenter or whether we have a guest, you're always going to get credit for attending e-shadowing and then watching a full 45 minutes plus of e-shadowing, then taking the quiz, getting at least a 4 out of 5 on the quiz, then requesting your certificate when the time comes. So yes, there'll always be credit for this. It's not an informational. And I put the website in the chat box. Alrighty, guys. Any questions? And if there's no questions, then I can jump right into the case study and then answer questions relating to the case study. Oh, looks like there are questions. What do you think is important to pay attention to when comparing what different programs have to offer? I think that's based on what's important to you. I think, of course, what's important to me is going to be price, of course. If that's what you mean, as far as going over, if you got accepted to multiple programs and trying to decide what you want, the tuition costs and fees, because you don't want to be in debt forever. Or if you don't care about debt and you will pay like $200,000 for PA school, then great. So basically what's important to you, if diversity is important to you, if they're big on community health, and they'll make sure that you get a lot of experience and a lot of rotations within the community and help you kind of get a job after. If schools help you get jobs, I haven't heard of a PA school that does that. That would be amazing if PA school kind of helped facilitated that. Usually it's kind of meeting your preceptor on rotations, and then going from there, kind of getting a referral from rotations or through your preceptor, or getting a job before you graduate PA school. But if the school doesn't really, at least from what I know, schools don't really help with that. So, but as far as choosing a school, it's really based on what's important to you. Is it the staff? Is it making sure you like the staff, the student demographics, the student profile, diversity, money, location. All that is based on what you like, your preference. All right. Any other? Okay. When shadowing, what should you bring? What should you do? And how long do you think is a good amount of time? Great question. So when I shadowed, I brought a clipboard with me to take notes. You don't necessarily have to bring a clipboard. Just bring a small notebook. You want to be engaged. I've heard PAs tell me that students would come and be on their phone the whole time. The only time you should be on your phone is when you're looking stuff up. And even then, don't do it like, don't make it seem like you're just on your phone texting and having a ball. You should not be on your phone. You should be engaging with the PA, even if it's like a shadowing opportunity that you did not necessarily want, but just, gotta do it because you gotta do it. Still act like you're interested. You don't want to be on your phone the whole time, because you're not only going to mess up the opportunity for yourself, but for others, especially during this time. PAs aren't able to accept students due to the pandemic. So if they do, be gracious for that and come ready, come asking questions, come wanting to engage, come, being very nice and appreciative, converse with the staff, converse with the doctor, ask to, shadow the doctor as well. You just be very open and ready to learn. So I say bring that, bring a clipboard or a small notebook or something, and that's really it. I mean, you don't have to bring much with you. And it depends how long you're shadowing for. If it's like, a few hours a day, you don't have to bring lunch. But yeah, and if they like you, they'll, want you to stay. They'll invite you to lunch. That's what they did when I shadowed. They'll invite you to lunch. It'll be a great opportunity. They'll want you to come back. So you just want to make a good impression on yourself. And then you're a PA student, so you're not only representing yourself, but you're representing other PA students, even if you're not trying to. That's just what it comes off as, and that's just what it is. So I represent other PAs when I work or when I, interact with patients. So you want to have a good impression. All right, and then as far as shadowing hours, I'm going to go off as far as what I had when I applied to PA school. I had 60. I shadowed for 6 weeks. It was every Friday. It was like a few hours every Friday, I believe. And it was for 6 weeks, and I ended up getting 60 hours. But before that, I did a few hours at my college, the clinic at my college. I shadowed for a few hours there. Excuse me. So I was able to get hours that way. So I say there's no set amount for PA school, like there's a set GPA requirement or not. So there's no set amount for shadowing. So I think a good amount is at least 50 hours. Of course, you want to get more than that, but try to aim for 50. Student who will be applied to PA school this. Any ideas on how to form a relationship with a PA so that I will be able to ask for a letter of recommendation, be able to apply to PA school? Okay, so yes, as far as getting a letter of recommendation, typically it will be from shadowing. You will want to build that relationship with the PA to be able to ask them for a letter of recommendation down the line. If you're not able to find a PA to shadow in person, that's fine. So I say to connect with the PA early on and hold on to them, right? So if you find one that's nice enough to message you back and be responsive, then don't ask them, oh, I'm looking for a letter of recommendation and want to know if you can do that. No, you don't want to do, you're not using people. You want to build a relationship with them first. So when that time comes, then it's easier to ask them for a letter of recommendation. And if you're applying for, PA school in May, June, you have sufficient time to build a relationship with a PA. And you can do that by going on, social media. We do have, the Med Assembly app where you can find other PAs to connect with, and it's not just for shadowing. Med Assembly is not just to find a PA to shadow, not just to find a preceptor for clinicals. It's to basically connect with PAs, to be able to build relationships with PAs, and it doesn't have to be a PA in your city. I wrote letters of recommendation for students from *eShadowing that I met via *eShadowing that reached out to me on Instagram, and they just kind of kept messaging me, built a relationship with me. I got to know them well. We eventually exchanged phone numbers. And then so when the time came, it was easy to write them a letter of recommendation because I felt like I knew them enough. So if you reach out to a PA on Med Assembly and they respond and you keep up that communication, you don't have to text them or message them every single day. But, a couple times a week, how are you doing? Or telling them about your journey, telling them about yourself, so they feel like they know you. So when that time comes, you have someone to write you that letter of recommendation. It's all about networking, building relationships, guys. So the Med Assembly app is, I don't know if you guys know, but it's a test app. We are launching officially to the iOS and Android stores early 2022. So if you do download the app, it is a test app. It doesn't have all the functionality and everything there, but will be brand spanking new and amazing when we launch soon. So if you still want to use it and test it, of course you can. And we have some mentors on there, and we're of course always working to make it great for you guys. I can put the link to download the app, and you can reach out to some mentors on there. Here, I can put the link in. So yes. It's really it's not easy to find a mentor, but we try to facilitate that, to try to make that a smoother process. Or it's not easy to find a letter of recommendation or whatever you may need to help get you into PA school. And I think that's a big hindrance because I didn't have one either. And I was kind of strategic about it because that's why I decided to shadow a PA for 6 weeks, 6 weeks as well, so they can get to know me well enough to write me. To write me a letter of recommendation when the time came. I'm just looking for the link, guys. Oh, here it is. If anyone is interested in downloading the app. Okay, and answer more questions. All right, let's see. Yes, this is e-shadowing. This is for applications. I've been doing e-shadowing for almost, this is over a year now, since November 2020. And students have gotten accepted using e-shadowing, so this will count for PA school. But Claire, make sure you confirm with your school that they do accept that. So, good evening. What would be your suggestions for a non-traditional applicant? How can I make myself stand out? Well, if you're a non-traditional applicant, that means you have a lot of life experience, right? Typically they do. Usually non-traditional applicants are usually, over 30, have kids, have a family, have had a prior career. You can make yourself stand out just by that, listing, not listing, but, detailing your life experience, what you learned from it, how it prepared you for PA school. Sometimes, even if you don't have a medical background and your prior career was in banking or it was being in the military, all that can, you of course got some experience and some developed characteristics that can help you with PA school. Military people are very punctual. They are very, what's the word, disciplined. So if you were in the military, that's a flex. If you did banking, whatever career you did before PA school, just flex on that. Okay. How do you politely ask for a long-term shadowing opportunity? I would first have the session with them if they've only shadowed for a day or two. So you shadow with them, and then you flex. You show that you really want this. You highlight yourself. You come ready. You come showing that you're very interested in the PA field. You're asking questions. You're engaging with the staff. You're very polite. Being polite is so important, guys. Like, these are not your coworkers yet, and be mindful of your words, what you say. These are not your coworkers. You are still a student, so be very polite, be very appreciative, grateful. So you do all that, and then at the end you would say, thank you so much for the opportunity. I would love to continue learning from you. Is there any way that I can continue this beyond the allotted time you gave me? I would love this, and if not, do you have another PA that you can refer me to? Because I would really love to, or I would really like to continue shadowing and learning about the PA field or PA profession. Boom. Maybe I should create a template. Okay. So to share us about what made you want to become a PA. What are some things you wish you had known before becoming a PA? Okay, what made me want to become a PA? I wanted to become a PA because of one of the main things, just to be frank, is because of it's not as long as a process as a medical school journey. So I chose PA. It would be, I would finish my degree, my bachelor's degree, then go to PA school. PA school is only 27 months. I didn't have to do a residency. I could get out there, start working. And it was that, and of course student loans. And then I feel like it seemed at the time, I think that's still the case, that it was aligned more with my lifestyle, as far as, I feel like should be true for every healthcare worker. Work should not be your life. I mean, anybody that has a career in general, work should not be your life. I know with different specialties, it's hard to have that work-life balance, but you have to make it, right? You have to make it what it is, especially if you have family, especially if you have kids. And not even if you have family and kids, you're a person. You have to live and enjoy your life before you know what you're gonna grow. Just kidding. But the point is that you want to enjoy your life, and that's what I wanted to do. Not that doctors don't, of course, but I wanted to be able to navigate, my career soundly. Let's say that. And PA school seemed like a better fit for me, for my personality. You just got to really know about, really dissect and figure out who you are and what you want out of life. I think that's the most important thing, and that'll help you decide as well. Oh, you guys have a lot of questions. Have you seen the recent changes? No, I haven't seen that. Some whoever asked me that question, somebody said CNA is not going to be considered as patient care hours. I haven't seen that. Is that a specific school or all schools? I would, if that's the case, I would check with the ARC-PA. The ARC-PA lists a lot. PA-EA lists a lot. AAPA. These are all PA resources and organizations, physician assistant organizations, and a lot of their information is factual. And of course, the school you're interested in. I have never heard of nursing assistant. Um, I've never heard of nursing assistant not being for patient care experience. Patient care experience is anything where you're hands on, directly involved in the patient's care, and CNAs do a lot as far as patient care. So I haven't heard of that. CNAs are actually like the next best thing to, our LPNs, RNs, as far as the patient care is related. So, and it's one of the easiest ways to, kind of get right in there and getting your hours. So I'm not sure if that's true or not. Was it in an email or on one of the organizational websites or school website? This is one shadowing hour. Like I said, I don't want to spend time answering e-shadowing questions. If you have e-shadowing, specific e-shadowing questions, go on eshadowing.com. What other career paths did you consider? Oh, girl, you don't even want to know. Oh man, I went through like a what you call it, a quarter life crisis. I wasn't even 25 yet. Listen, I considered I would change my major. What was I in when I started college? I don't even know if I had a major yet. I was either pre. I think I was pre health. I was pre health. I couldn't pass Math 1147 at UF. It's pre-calculus. I dropped pre-calculus. I changed my major to nursing. I was just like not focused at all and like borderline like depressed, like just not like lost, basically lost for like 4 out of 4 of my college years. Okay, maybe 4 out of 4 up until like towards the end of college. I keep it real with you guys, but yeah, and because things were just not going right, I came into college, in the hopes of being a doctor. If you guys know my story, you know that like I'm not going to go super detailed. A lot of it is on YouTube, but that didn't happen. Of course, I didn't go my way. Life. So then I did nursing. It wasn't what I really, really wanted to do. I wasn't like as focused, and I didn't get into nursing school. I got waitlisted at UF's nursing school, and then I was just like, okay. And I'm like, maybe I'll become and then I was like, okay, let me major in psychology. I'll become a psychologist or sociology, get my PhD in psychology. I talked with a psychologist, and I wasn't really that impressed. But I was still gonna say, oh, let me get my PhD. It's just not me. And then I was like, okay, I like to talk. But then I'm shy, and I'm like, okay, I'm gonna become a talk show host like Wendy Williams. True, guys, true. I'm a mess. So I'm like, okay, I'm gonna become a talk show host. I'm gonna get into the media. I'm gonna become like a journalist and whatnot. Listen, I went through like really trying to figure my life out. And then I was like, I'm so lost. I'm gonna study abroad. I studied abroad trying to find myself. I spent 6 weeks in Italy trying to find myself, still lost. Then I came back. I was there from like the summer. Sometime I don't remember exactly when, but I came back and I was just working. And then that's when I saw like I either saw a PA walking down at the nursing home I worked at, like walking down the hall, or I saw like his name on the chart, and then that kind of just a light bulb just went out about the PA profession. And then that's when I did my research, and because they would always be at the nursing home, but it just like I just never put 2 and 2 together that this could potentially be a career. So then that's when I did my research. I'm like, okay, I'm gonna do this. And I'm like, if it doesn't work out, it doesn't work out. But if it does, it does, and I'm gonna be a PA. I just went for it. I just went after. I'm like, I need to do something with my life. I'm just gonna do this. And that's how I became a PA. And that's just me trying to, taking the leap of faith, a big leap of faith, and hoping that it works out, because I was like so completely lost. And I'm like, and I'm just like, I'm a big believer. So I'm just like, if this is meant to be, it's going to be. And it did become that. So not that I'm like any, better than anyone. I went through a lot. A lot of self-finding. What do you think made you stand out in your resume for applying to grad school? I think they were really, really impressed with the fact that I got an LPN in college. I'm not college, high school. a lot of people, but I kind of razzle dazzled it. I said that, I, sacrificed so much to get my LPN. I was, I missed so much in high school. I didn't miss prom, but I missed a bunch of pep rallies. I missed, this and that. I couldn't attend senior skip day. I couldn't, I didn't say that, but I really missed a good chunk of my senior year devoting it to nursing. And I said, I was 17. I stressed on my age, how young I was when I got it. I wasn't even legal and working, at a nurse. Well, not working, but doing rotations. So I think they were really impressed with that because a lot of, my professors asked me about that when they interviewed me. CASPA just changed it. Really? I have to see on CASPA. Okay, so I'll take a look at that. Do I know of any travel PAs? Yes, I'm a travel PA when I want to be. I don't know if CASPA changed that. I would still talk to that school. Do you ever feel like you aren't smart enough? Yeah, heck yeah. Until you get something right? Until you actually diagnose a patient. Yes, I feel like imposter syndrome is just a never-ending thing. You can have years and years of experience. It happens to the best of us, and it doesn't mean anything. It doesn't mean that you're less than. It just means that you're human. You know, you know your limits, or not even know your limits. You just are aware that you're human, and it's okay to have imposter syndrome and feel like you're not smart enough, but definitely we know that you are, because when that hits you, that feeling of I'm not good enough, I'm not smart enough, am I able to do this? Just think that okay, you're able to do this because you're in that position. If you weren't able to, you wouldn't be there, and just kind of reflect and think about all the times, all the things that kind of get you to that, got you to that point. So, where have you worked at? Where have you enjoyed working as a travel PA? I actually, I've worked in Florida and New York as a travel PA. Actually, and I don't like New York State, but I like the hospital that I worked at in New York. I really enjoyed that hospital. I mainly enjoyed it because of the staff. I didn't like it at first because they were kind of mean, but when people are mean to me, I just be nice to them. Or when they're like mean and just not like mean. I've just realized kind of New York people, you just kind of have to get to know them. That's kind of just their personality and their blood. So I would laugh it off. And yeah, I ended up really loving the staff at that hospital. And that was my favorite one. That was like the only, I did one in New York, but I didn't have a good experience. And I'm just kind of looking, I would just go back to New York because that's where most of them are. New York, a lot of them, I'm not going to say most, New York and California, but getting a California license, I know I need to get one. I would have more opportunities, but it's annoying. So I haven't even started that process. But New York, California, Texas tend to have a lot of opportunities for travel PAs. No, I've never done a travel job out the country. Wow. So someone just said a very impressive, not resume, but very impressive stats. I'm a non-traditional student. I'm a 38-year-old mom of 3. Amazing. Registered respiratory therapist for 8 years, 12 years experience as a CNA. So you got that down. Graduated cum laude, and I feel too old to apply. Negative. Have you seen people my age range get accepted to PA school? Heck yeah. The oldest in my class was in her 40s, like 42 at the time. So it's not the question of getting accepted. It's the question of you applying. You better apply. Yes, you will definitely get accepted. Don't think that you're not able to get accepted as a non-traditional student. You have so much to flex about. So it's also a question of just making sure you have that support system to complete PA school with everything that you're responsible for as a 38-year-old mom of 3, which is amazing. But just make sure you have that support system because you'll definitely need it in PA school. Everybody will need it in PA school. What I always say that non-traditional people, they got like real life responsibilities. Okay, when I was in college, I didn't have like real life responsibilities. When I was in my early 20s, it was but it's different when you have kids, a family, bills to pay that you don't have like parents to really help you with. So I salute you guys. What are some things to look for in PA school besides distance and cost? I always say the most important things to look for is making sure they're accredited and their PANCE pass rates. Those are the 2 most important things to look for. They're making sure they're accredited and their PANCE pass rates. And other things, their mission, making sure it aligns with you, who you are, what your goals are as a PA. And they'll likely ask you that also. What do you think about our mission statement, or explain the mission statement? They'll ask you something like that on the supplemental application. So really make sure you study the school, go on their website. I used to go on my school's website like all the time, like stalk their website, study their website, read everything, study their professors. I would look that up too, read about their professors. So if you share something with them, you can ask them that. Like one of the professors at my PA school, she was an African American female. She was not only a doctor, but she was a lawyer. So I thought that was so cool. Even though I don't want to be a lawyer, I just think it's great to be an African American female and have that level of education and see somebody in that position, that I can relate to. So I thought that was great. And so yeah, so any little thing can really impress you and get you wanting to go to that school. Okay, somebody asked about the essay. I have a lot of things about the essay. I kind of skipped over that question about the personal statement because I have a lot of resources about the personal statement, about structuring the personal statement, how to start the personal statement. I can, if you have questions about the personal statement and want the resources, just email me, because I don't want to spend too much time discussing that because it's a lot. So I put my email here. Okay. Was there ever a moment you felt like being a PA wasn't for you? Yes. Yes, there was a when I felt like being a PA wasn't for me. Yes. Or when it's not felt like being a PA specifically, but just in healthcare, because you just get so stressed with patients and just it's really due to the stress level. It was never like PA wasn't for me. It's just more so healthcare, being in the medical field and everything that comes with it. I wouldn't even go as far as the whole CNA and patient care hours. I would notify your school. I haven't read that. I haven't read that yet, that article, but it's what your school says. CASPA can say one thing, but it's what your school wants, right? So I would confirm that with your school of interest. Alrighty, guys. You can shadow a PA or a physician. I don't recommend you shadow an NP. They don't generally count that as shadowing hours to shadow a nurse practitioner. Tip on how to phrase asking for a lot of recommendations. Okay, I can create a template. I know I've been saying I'll create a template. I will create a template for you guys. I know there's some templates out there, but I will create one as well. If I create anything, I'll post it on the MedSembly app. It's under the discussions tab. Whatever I create, whatever I post, all the resources are usually there. All right, you guys. All right, I'm going to do the case study now, guys. Okay. How many of you are new you guys see the case study? How many of you are new here? Should I email about tips on shadowing in Miami area? Finding a shadow in Miami area? Ooh, that's hard. You can email me, or I can try to answer that after the case study. Okay, so it seems like you guys are new, so I'll excuse me, discuss how I do my case study. If you guys don't know, I'm an ERPA. I'm like trying to kind of back away from the ER though after like 3.5 years. I probably will only do it if I decide to travel. But right now I just mainly do urgent care, which is very similar to the ER, except you see lesser acuity patients. The ER, of course, is more of a life and death type of thing. Urgent care is more for more stable patients that can be treated and go home. A lot of times they may need to go to the ER, so have that discernment there. If you feel a patient in urgent care needs to go to the ER, just refer them to the ER or call the ambulance for them. So I do work in urgent care more now. So I've been in the ER, or I was in the ER for 3.5 years. The majority of my PA career, I've been a PA for 5 years. So the majority of it just been, well, all of it really has been ER and urgent care. Okay, so in the ER, whether you guys do ER or not, you have to always recognize this for any patient that you encounter in any field. You have to make sure that the patient is stable to do anything. And especially in the ER, you're always going to be thinking worst first, right? Because people come to the emergency room for life and death situations, even though that's not always the case. As a medical provider in the emergency room, you have to be thinking that to always rule out the worst possible thing. And even if it's something super simple, Your documentation has to confirm that you've ruled out the worst possible thing, whether, of course, your documentation, but the exam you do, which is with your documentation, the tests you order, the labs, the imaging, all of that has to confirm and align with you saying, okay, I ruled out the worst possible thing, or I figured out that the worst possible thing is going on, and this patient needs that type of care, or this patient is stable to be discharged with this treatment plan. So always, always, always be thinking about worst first. When you start your rotations in the ER and you get to examining your patient, they let you see your very first patient, and then you present to your preceptor, you're going to tell them, so my differential is this and that because I want to rule out the worst first and this and that. They're going to be so impressed with you, okay? And you're going to say, I learned that before I even got into PA school as a pre-PA student from Rodolin Joseph at ep56.com with MedSembly. Okay? Period. Anyway, they're always going to be thinking about what can kill your patient. Is the patient stable or unstable? Can they go home? Do they need to be admitted? Do they need to be transferred? Those are the three dispositions, or of course, if they've expired, but you don't want that to happen. And then pearls. Pearls are just important things to know. They can be common things, just things to know in the ER. And then you're going to always be consulting your attending or the specialist, any specialist, the internal medicine doctor or the hospitalist. So yes. All right, this is our case study for today. Why did I say new arrival? I think that's the title. Okay, anyway, a 19-year-old male presents to the ER with complaint of CO is complaint of. We try not to use abbreviations too much in healthcare, but I mean we do anyway. When you see like the chief complainer, when nurses write on the board or whatever, a lot of them will be abbreviations just because it's just between us. But with complaint of cough, runny nose, fever, body aches, congestion, times 2 days. All right, so what should you be thinking about? What would you ask this patient? And first and foremost, you are going to be looking at your vitals. When you're gonna know the patient's vitals before you even see the patient, right? Because you're gonna pick up the patient, you're gonna open up your charting system, Epic, Meditech, whatever charting system your hospital uses. You're gonna open that up, sign into work. See the tracker. The tracker has a list of all the patients, everything, the flow, whatever going on in the ER. And then you'll see the patient name, either their age or date of birth, their sex, and then the vitals. I mean, not show all the vitals, but you pick up that patient, with whatever method they have, and then you open the patient's chart, right? You want to always open the patient's chart. Sometimes you won't. Yeah, you can always open the patient's chart before seeing the patient. That gives you an idea. Sometimes when it's really busy, I'll just pick up a bunch of patients and go see them and then kind of do everything, out of order. That's when it's super, super busy. But this is good to do, kind of read about the patient before you see them. Like I said, I do it out of order sometimes, but I always make sure to at least read about them before, they go home or before I tell the doctor about them or whatever. So you'll read their vitals. You'll see their vitals. That'll give you an idea of how sick they are. So looking at this patient's vitals, what are you guys thinking? Stable, unstable, sick? Well, I mean, they're all sick, but let's just say stable or unstable. Is this a stable patient or is the patient unstable? Alrighty. I don't want to butcher your name, but Bubakar. Yes, good job. Everybody's saying stable. Yes, perfect. So the patient's vitals are pretty stable. They're normal, right? And the majority of the patients in the ER are going to be stable. If they're not stable, a lot of times the doctor will see them. And sometimes they may not be stable. And if that's the case, you kind of got to act quick. And but if just because they're stable, it doesn't mean that there's nothing going on, right? You still have to do your due diligence and make sure this patient can go home safely, right? So just because they're stable doesn't mean that they won't become stable like this, because that can happen. So yes, just be very cognizant. All right, so this patient is pretty much stable. All right, so what are you going to ask this patient? What are some important questions you want to know with this in mind? The past medical history, past surgical history, family history, social history. PMH is past medical history. So what would you want to ask? Okay, before you even kind of go into detail about this, what do you want to know just in general? Just what do you want to know? Okay, great. So you want to always start, this is kind of an investigation, right? So you're talking to this patient, you want to know what's going on. So you introduce yourself. Hi, my name is Rodolin. I'm the PA taking care of you today. What brings you in today, or what's going on? Hi, I'm just having a cough, runny nose, feel congested, just feel sick. Okay, how long have you had these symptoms? I like to ask the questions over just to make sure they align with everything. Patients will get annoyed that, they're like, oh, you're the third person to ask me. You're the fourth person. I've answered this so many times. But sir, I'm your provider, and I just want to make sure that everything aligns, that I get an accurate history. Boom. All right. So how long you've had it? I've had it for about 2 days. Okay, and then being that he's having all these symptoms, I kind of go into any other symptoms you're experiencing. And with this, an important question to ask is if they're oh, you want to ask kind of different body systems, or you ask things from important things from different body systems. So for this, what would you ask? Just kind of from the kind of a neuro perspective, because you want to rule out worst first, right? Worst possible things, right? Because what does it sound like he has? What does it sound like he has from based on his complaints, guys? So you guys have some great questions, but what does it sound like he has? And I'll let you guys know where I'm going with this. It sounds like he has, yeah, the flu, just kind of he's cold. Yeah, right. So this is a pretty much, something straightforward, right? Like you'll feel really sickly and bad, but you're not gonna die, right? But are you? Just kidding. Okay, but yeah, so it's something pretty straightforward. But this is the case, or with any case, you want to rule out the worst possible thing. And what I do with patients like these, I ask them important questions to rule out important stuff in other body systems. So neurologically, I want to rule out meningitis. He has fever, so I ask him, do you have a headache or neck pain? If he says yes to both, then I just make sure I really do a good exam with the meningeal signs, Brudzinski, Koenig sign, and all that. But you want to make sure that it's not meningitis. You want to make sure that it's not pneumonia. You want to make sure that it's not a bad gastroenteritis or something surgical going on in his belly, especially with the flu. Oh, I said fever, but his temperature is normal. He took a Tylenol before he came here. But yeah, so it seems pretty straightforward, but your documentation has to say that I ruled out other stuff. So you ask them, have you had any other symptoms with this? Do you have a bad headache, any neck pain, any chest pain, any trouble breathing, any nausea, vomiting, diarrhea? If he has all those, he could be super dehydrated. Any nausea, vomiting, diarrhea, abdominal pain. He says no to all those. Boom, you document, you cover your stuff, you check all that off on the review of systems. And then you go on to, have you taken anything for the symptoms? I've just been taking Theraflu. Okay, great. And let's see. Anyone around you been sick contacts, especially if they have sick kids in daycare, a bunch of them do. No sick contacts, any recent travel. You want to be thinking about, like, recent travel, you can get anything, but especially in this day and age, it's COVID. Any recent travel, anyone, you said already said anyone around you been sick, so that's good. And are you vaccinated either for the flu, for COVID, whatever? No, I'm not. Okay, boom. And let's see, any medical problems. So if they have like lung problems, you know that this can be, can easily become a pneumonia. If this was an 80-something-year-old, you want to, be more precautious, right? You don't want to just say, oh, this is something simple. You want to make sure that it's not a pneumonia, or that, you want to do a little bit more if the patient has comorbidities, or they're really old or really young. So I think we got everything. Are you eating and drinking okay? Does the medicine help? If the medicine helps, why are you here? I'm just kidding. I be thinking that, like, okay, if the medicine is helping, why are you here? It's gonna go away. Okay, anyway. So yeah, so the point of this case study is really to give you guys something really straightforward, but to remind you that you have to think about worse stuff. Just because he has all this stuff, it doesn't mean that he doesn't have meningitis or won't become a meningitis. So right? So you have to ask those questions. You can have I'll tell you guys later. So okay, all right. Focus history. All right. What would you? Focused. Oh, sorry, I put that twice. Wait, no, we already went over that. Okay, focus history. Okay, we don't like I've said this before, but a lot of these other questions, what I usually ask for is past medical history, because everything else will usually be in the chart. Typically, the nurses ask like all these other questions, and then I'll ask about smoking and tobacco, alcohol, if it's like pertinent. which you can hear. But a lot of these other things, family history, surgical history, unless it's something surgical I think is going on, will be in the chart already and I'll see it. But I usually always ask about past medical history. I like ask them myself. But a lot of times this will already be in the patient's chart. Now you're doing it as a physical. What systems do you want to assess? I'm just looking at all your questions, your history questions, which is all good. Great. Yes, yes, yes. Okay, so I tell you guys to always listen to heart and lungs, and especially in this case, you always want to listen to heart and lungs, see if you hear any thing crazy going in his lungs. Neuro, you can do a quick neuro. Usually for this, I'll just make sure that their neck is not rigid, that there's nothing like meningitis going on, and you document that. You document no knuckle rigidity, no meningeal signs. And that helps you, that covers you, because you do not want to miss a meningitis. So yeah, that's really it. You can kind of touch their belly, make sure their belly's soft, make sure that it's not tender. But that's basically it. Listen to their heart and lungs. If they have a fever when they come in, or if they don't have any like other meningeal signs, you're good. That's it. And if their heart and lungs sound good, boom. What lab test do you want to order for this patient, and does this patient need any medication? Okay, somebody said CBC. I wouldn't do a CBC for this patient specifically. Why wouldn't you guys do a CBC or CMP? Or why would you? If you're gonna do something, you gotta say why. You have to have an indication, right? So why would you think this patient needs a CBC and CMP? Why do you guys think this patient needs a CBC and CMP? Okay, so for those that said that, I wouldn't do that because one, this patient has this patient's young. Symptoms are pretty straightforward. Vitals are very stable. This patient doesn't look sickly. It sounds like it's just something. CBC wouldn't really tell me anything, right? If they have a white count, okay, then I'll do a chest X-ray. But I wouldn't really go beyond that. I wouldn't even do a CBC in this patient's case because their vitals are so stable. The patient's stable. The patient has. I'll tell you what the patient has, but yeah, it's not anything where you kind of have to do anything besides these. Oh, before I go into that. Okay, imaging. Does this patient need any imaging? Oh, somebody said x-rays rule out pneumonia. A CBC is a complete blood count. It is a blood test. So it'll look at your white count, your hemoglobin, your hematocrit, your platelets. A CMP is a complete metabolic panel or chemistry. It looks at your electrolytes, your kidney function. Like I said, if this was an elderly patient, I would do just a basic CBC, CMP, chest X-ray. But this is a really young patient, no medical problems, look good, O2 stats good. He's breathing room air, speaking complete senses. He's a little congested, but who won't be with the cold? So, okay, this patient may need a chest X-ray. It's just kind of based on the provider. Some providers will, some providers won't. You're not wrong if you do. You're not wrong if you don't. I think so. It's for this type of patient. If you do, you likely won't see anything. It's kind of just reassurance that this patient doesn't have a pneumonia, which is less likely that this patient has a pneumonia after 2 days and after normal vitals and after lungs are clear, oxygen that's good. He's 19, so he could have a pneumonia, but we generally don't suspect it. So if you want to do a chest X-ray, you can. This is I don't see anything. So there's no pneumonia going on. It's a clear chest X-ray, and that's just another thing to document and say that, oh, there's nothing going on. All right. So this patient has a respiratory tract infection, right? The respiratory tract, it can also include your ears, because you can have like an otitis media or an externa, and they're all like connected. But the respiratory tract, there's upper and lower respiratory tract. It's from your nasal cavity down to your lungs, and this is all the everything included in the respiratory tract. So this is just an outline of the respiratory tract. So the cutoff is basically kind of when it gets to the trachea. So this is like all upper respiratory, like all the head stuff. And then when it kind of goes down past your neck and into the bronchi and the lungs, that's lower respiratory. And I want to discuss this because this is like this time of the year. This will be probably, if you work urgent care, this will be a good 80% of your patients, 80 to 90% of your patients. If you were in the ER and you're working fast track is more stable, level 4 patients, kind of in and out stuff. This will also be like 80% of your patients. because it's that time of the year. People, it's cold weather, the weather change, season change, whatever. People are getting sick. So yes, so be prepared to see this. You'll see this. This is, I think I read that this is like the most common complaint in like primary care, and I think just respiratory tract infections. So that's why I wanted to go over this. A lot of times they're straightforward, just kind of in and out type stuff, but you want to always document the bad stuff, that it's not the bad stuff going on, right? It doesn't mean bad stuff can happen, especially with at-risk populations, but at least when they see you, you make sure that, oh, there's nothing bad going on. And if it's urgent care, it just be in and out. Urgent cares are getting slammed now with upper respiratory tract infections, COVID type stuff, whatever it is. And it's just named for wherever it's going on in the respiratory tract. Right, so like I said, this is upper respiratory tract. Once it goes like past the trachea, it's like lower respiratory tract. So yes. All right, so this is what I would order for this patient, and a lot of you guys were right. You don't always have to order a strep with kids. I do all the time with kids. They always have sore throats. But this is like the trio. It used to be just flu A, B, and strep, but now of course COVID too. So this is what I would order for this patient. If all three are negative, hit the road, Jack. But yeah, I would order this workup for this patient, and that's it. I don't think this patient needs any blood work. And you just say that, verify or back that up with your documentation of why this patient doesn't need blood work or anything else. I may or may not do a chest x-ray, but this is really it for the workup on this patient and respiratory tract infections. And I'll tell you why. The reason why is, I should have had this one first. Okay, the reason why is because 80 to 90% are viral. There's not much you're going to do anyway for these patients as far as treating them if they're stable. They don't need antibiotics. They'll beg you and insist that they need antibiotics. I'm not going to lie. Sometimes I just don't feel like hearing with their mouth, and I just give it to them, that Z-Pack that they beg for. So usually symptoms last for about a week, 10 days. Bronchitis is more lower respiratory, but when you have bronchitis, tell patients this, symptoms can last for up to 2 weeks. You'll have that, that awful, annoying, lingering cough, or you can have it for up to 2 weeks, 2 or 3 weeks. So as long as it's a pneumonia, and then that's when doctors usually, or providers usually end up giving a Z-Pack when it's kind of lingering on for that long. But typically they don't need antibiotics because it's a virus. Antibiotics are for bacterial infections. So that's what I explained to them. They still be like, oh my gosh, my doctor gave me a Z-Pack last time and it knocked it off. It does show that Z-Packs kind of help with the symptoms and patients feel like, oh, it's doing something. But listen, sometimes you just don't want to go back and forth with people. So, but just know this, and this will be on like every pharmacy test that you take that's related to upper respiratory infections, and this will maybe on the PANS. This will definitely be on your PA school exam, so know and remember this. Is that even more so with the pandemic? I haven't really seen that. They've just kind of always been annoying when it comes to that. Okay, so these are basically all the upper respiratory tract infections. Rhinitis, the nose, sinusitis, your sinuses, pharyngitis, your throat, tonsillitis, your tonsils, laryngitis, your larynx or voice box, they'll lose their voice. Epiglottitis, the only one that's really, unless they have a peritonsillar abscess that needs to be drained, but the only one that is a true medical emergency where you need to just be on it is epiglottitis, because your epiglottis that covers your trachea and stops food from coming in to your windpipe is basically closed and you can't breathe and you can die. So that's the only one where that is a true emergency. Okay, if the patient has epiglottitis, you better be on it. Hopefully, they can. And it's a long thing. You may not be able to intubate them. They may need a trach, but it's a bad thing. You don't want to see a patient with epiglottitis, and it's actually not as common because of what is it, the a vaccine, because I forgot what virus causes epiglottitis, or no, Haemophilus influenza. H influenza, I think that's what it is. Listen, I'm so far removed from PA school. So, I believe it is H influenza, but I haven't seen epiglottitis ever. It's just one of those things that you learn in school that they tell you don't ever miss this, and you don't miss it. So, or you try not to miss it. You try to it always just sticks with you. So these are the URIs. And sinusitis can become bacterial. You know, pharyngitis can be strep, but not all. Most pharyngitis are not strep. Strep is a bacterial infection, so that's how we test for strep. Most pharyngitis are viral. Same thing with sinusitis. Usually, if it's like over 10 days or 14 days or so, then we give augmentin or azithromycin for bacterial sinusitis. And if it's like recurrent, then they kind of see ENT and stuff. Same thing with pharyngitis or tonsillitis. Okay. So the reason why I say that, you know, we don't really do much is straightforward and like, why are you here? Is because, you know, with viral illnesses, it's a virus. It'll kind of run its course. The thing is, you get lots of rest, stay hydrated, treat with over-the-counter medication, symptomatic care, treat the symptoms. I tell me if you have a cough, take cough medicine, body aches, Tylenol, Motrin. Usually with Motrin, usually with COVID, we don't give Motrin, we just give Tylenol, Theraflu, whatever it is that's making you feel better, you do that. You're gonna feel sicky, you're not gonna feel well, you're gonna feel like, oh my gosh, you know, I'm terrible, this is terrible, but it'll eventually go away. When it's not going away or when it's getting worse, that's when you know, come back or when you get admitted. When we admit is when it becomes a pneumonia, like a bad pneumonia. They're unstable. You always got to think of stable or unstable. If they're septic, and you'll kind of have a hunch if they're septic. That's when you do the blood work and everything. You know, it'll tell you by their vitals how the patient looks, how the patient appears to you. If they're super unstable, like their oxygen's low, they have COVID, or you know, they told you they have COVID, or you suspect COVID and they look bad, they need to be admitted. Okay, they get admitted. If they're dehydrated, you can have abdominal complaints with URIs, especially with adenovirus. You have like the diarrhea, the abdominal discomfort, the vomiting. So if they're like not wanting to eat or drink and they're super dehydrated, kind of admit them for comfort care, comfort measures, fluids. But typically, most of the time, unless they're really old, really young, have crazy comorbidities, it's going to be something straightforward. But always, of course, remain cognizant and still do a good exam, still ask some necessary questions, and treat as indicated. So I say know what's common, no zebras, like epiglottitis is basically a zebra at this point, but it could still happen. And know what can kill you, like epiglottitis. Yes, kids get it a lot and they'll be tripoding. Kids are at risk for it. Yes, kids are typically at risk. Why Toradol? Oh, what about Toradol? You can give Toradol for body aches. It kind of helps them make them feel better. Toradol is like a shot of ibuprofen. What is zebras? Zebras are basically things that you should know, things like that can kill you, but that you may never, ever, ever see ever in your career. But that when you see it, you better know that it's, you know, it is what's going on, like epiglottitis or necrotizing fasciitis. It's because it's like a zebra. You may never see it in your life, but when you do see it, you better know what it is, or not even know what it is, but know some of the symptoms so you can. It helps you. Like hypertension is not a zebra. Hypertension is so common, or appendicitis is not a zebra. Yeah, but zebras can be, like I said, epiglottitis or the most common one I know is necrotizing fasciitis because it's so life-threatening. So yeah. Alrighty, that's the end of this case study. I know it was I hope it was super easy for you guys, but like I said, the point is to make sure that you guys really understand the gist of emergency medicine and urgent care, and how to always remain aware and always do a good assessment, even if it's something straightforward like upper respiratory infections or URIs. You'll be documenting about URIs like all the time around this time of year, especially. So, but don't get caught up in just, you know, oh, it's just the URI. Oh, it's just a URI. I'm just going to tell them to take Motrin, get, you know, some rest, and it's okay. No, you'll get that patient that, oh, no, it's not just the URI, it's a meningitis. So just be careful. I've had patients that I diagnosed with meningitis, and someone put sinusitis. So, and it wasn't a sinusitis, it was a fungal meningitis, and they're giving him bacterial augmentin. So yeah, always still, even with the simplest things, still do your job and, you know, be good. All right. I get this tingling feeling when I talk about medicine. Must be love. Alrighty, guys. It's 8 o'clock. We finished right on time. Any questions about the case study? Any questions at all about anything? I saw people wanted to speak. Anyone still want to speak? I'm glad you guys enjoyed it. All right, make sure to follow me, follow MedSembly. All right, do you guys have any questions? No, I'm not based in New York. I'm based in Georgia. Where can we find the quiz? The quiz should be posted shortly after this session. If not, then tomorrow. Have a great holiday, guys. Merry Christmas. Happy New Year. See you guys in 2022. Remember, there won't be e-shadowing next week, the 27th. But make sure if you have any questions, so feel free to email me, message me. Yeah, so be good, be great. Make sure you know write your goals for the new year. And yeah, see you guys. Thank you. Bye.